All right, so recovering from concussion. To start this off, what I wanted to do is tell you a little bit about my background. So my background is in actually athletic training. It's where I started my undergrad. And in undergrad, athletic training, you deal with a lot of sports injuries. And one of the sports injuries that you do deal with a lot is concussion, and you evaluate for concussion. So we went through the training for concussion, and I remember when I first did the evaluations, I thought it was kind of cool. We're checking nerve functions and everything, and found out most of what we're checking field side test wise is cranial nerves. And at first I just thought, hey, those are cranial nerves. That's kind of cool. But the more I studied, and then especially when I got to grad school, you find out that these cranial nerves that you're doing these tests for tongue movements and facial movement and eye movement and the ability to focus with eyes, all those kinds of tests are actually rooted in the brainstem, with the exception of only one, the sense of smell, your olfactory nerve. The olfactory nerve goes straight to the cranium, the back of the brain. All the rest of them go to the brainstem, which sits quite a bit lower. And so when you take a look at it, here's the brain, and highlighted, I think I can bring up the drawing tools, but highlighted around it is the brainstem right here. And so that brainstem actually sits pretty low in the brain. And I thought it was a little bit interesting that we kept calling it a brain injury, but it really seemed like, at the time, a lower brain injury. Now, when you look at the skeleton over top of it, what's really interesting is this brainstem actually, in some people, will go as low as, it'll go as low as the bottom of C1 and a little bit into C2, and some of the nerves that are in the brainstem will also go there. So it's a very interesting perspective when you start to say, hey, we keep calling concussions a brain injury, and yet most of what we're testing and the first signs of concussion are very strongly related to the brainstem. So this is kind of like the first thought I had that said, hey, do we totally understand concussions, or are we assuming it's a brain injury? And so, I actually joined the military when I was 18. This is a picture of me when I was probably about 10 years ago, 11 years ago, in the military. I remember we were watching a video of mild traumatic brain injury. And in this video, they were showing this example of the brain smacking the inside of a jar. And what'll happen is you grab the jar, right? Someone will put an object or a fake little plastic brain inside of it that's about the same density of water, so it'll kind of float in there. And then they'll shake this jar, and it'll cause the brain to smack against the side of the jar. And they say, see, this is how concussions work. And I looked at it, and I remember the day we were watching that video, and I go, that's not actually how it works. And it was in the military that I saw this video. I said, that is not how the brain works. I know that's the model right now, but it doesn't make sense. And then I saw, I don't know, how many of you, go ahead and type in here, did you guys see the movie Concussion with Will Smith? Go ahead and type in if you have or not. I'll keep moving on while you type that in. But in this movie, you can see right here, he's explaining to his girlfriend, let me make that red really quick. But he is explaining to his girlfriend that when you get concussion in this jar, the brain that's sitting right in here, it will smack against the side of the jar and impact the side. And that's how we get concussion. Now, what's interesting about this, both in the military version that I saw, that looked a little bit more like this, and in the movie Concussion, is that the jar is actually never all the way filled with water or fluid, whatever it is. In this movie, it's actually half full. And so he's slamming the brain against the side of the jar, and yet the jar is half air, half water, and then a brain sitting inside. In this one here, you can see at the very top, there is still air in here. And so what happens is when you use a jar that has air inside, what you're doing is setting up a model for concussion that includes both hydrodynamics and aerodynamics. But inside the brain cavity, there is absolutely no air and no aerodynamic qualities to the movement of either the brain or the fluid within it. So a common way people talk about concussion is they call it sloshing. But sloshing is an effect of water that can only take place in the presence of air. And if you remove all the air, it can't slosh. And so when I saw this first in the military, I remembered I was probably about 8 years old, and my dad, he got this jar, a mason jar, and he filled it all the way with water up to the very brim. And he found this piece of plastic that was about the same density as water. And he sealed the lid. He put it in. He sealed the lid. So literally there was no air in this thing. And he challenged me. He said, make that thing smack against the side of the jar. And I would sit there and I would be pounding and I would be shaking this jar. And it never actually hit. It would get really close and then slow down right as it got to the edge. And I could never get it to hit the side. Because as soon as you remove all the air, all you have left is pure hydrodynamics, and water and fluid does not dissipate as fast as air. So he'd be sitting in the kitchen laughing his head off because he thought it was so funny that I was trying so hard to get this piece of plastic that was the same density to smack against the side of the skull. And he didn't realize this, obviously, that he was actually showing me the model of how the brain does move inside the skull when it comes to a direct blow impact that often happens during a concussion. So then when I finally saw this video in the military and I saw the movie Concussion, I realized we keep propagating a model that doesn't exist inside the brain. Nobody's using a model where they remove all the fluid and see what happens there instead. So it really got me thinking, all right, what about the size of the brain, size of the skull, and the amount of space between the two? A glass jar and egg isn't even the right proportion to head and brain, right? Yes, it's not, Dawn. You're absolutely right. In fact, there would be an even slower dissipation of force because the brain does fill up so much of the cavity. And I'm going to talk about the way it could likely work in the presence of only hydrodynamics, but I just kept noticing that this model wasn't right. So I said, we have got to figure out what concussions really are, because we don't seem to have much of an answer. And the best answer we do have, especially right now in sports, is to just not play if there's too much concern. But it doesn't seem like we're nailing down the root cause of why some people continue to go downhill. The movie Concussion brought to light the touchy subject of chronic traumatic encephalopathy, CTE, which a lot of these football players are getting, but you can't diagnose it until they're dead. And then you do an autopsy and look at their brain. So we have no living model to figure out if this person is even susceptible in general to a concussion and the long-term effects that concussions can have on the brain until they die. We're getting a little bit better at imaging to see some of the effects of it, but that is where we're at right now. So I'm looking at it, realizing we really need to investigate this. So what happened is, let me switch these slides around. This last year, I got together with some other doctors and we did a research project, and we were talking about mild traumatic brain injury. And the reason why is, in sports, there's a lot of defense where a lot of people don't want to talk about it because they feel like if they talk about concussion, it's suddenly going to end players' careers. But in the military, there's not as much resistance because we really do want to help our vets and serve our vets. And so there's a lot less resistance that I've noticed by going the military route and talking about mild traumatic brain injury as opposed to concussion. And so that's exactly what we did. We took a look at MTBI and used it as the route to cover both MTBI and concussion, because MTBI is essentially concussion. But the way military people get concussions is far different than the typical soldier, especially the typical combat soldier. So these are the actual stats. Between 2000 and 2017, 379,000 MTBIs among military personnel. That's how many we've been encountering. That's an average of 21,000 a year. It's insane. And a huge amount of that is due to blast injuries. And if you think about the way we fight right now, we have a lot of soldiers that are armored up in armored vehicles, and they're encountering a lot of IEDs and roadside bombs of different sorts. And so instead of getting flesh wounds, because the flames and the shrapnel is not necessarily cutting through the vehicle, but the force of the impact is still tremendous. And then when people are on foot and they encounter those explosions, they actually are getting multiple types of injuries all at the same time, but it does include a concussive blast. So some of the symptoms that a lot of these soldiers are getting include headache, which is a really, really big one, especially post-concussive syndrome. And it seems to last a lot longer in soldiers than it does in athletes, but a lot of athletes have it and don't talk about a lot of the long-term effects because they don't want to lose playing time. So headache is a big one. Sleep, sorry about that, I'm moving something up really quick. Headache is a big one. Sleep disorders is a really big one. They don't sleep as well. You can't think as well. Ringing in the ears is very common. Balance issues and dizziness is really common. And then there's all the cognitive issues, not being able to focus, not being able to pay attention. Basically, just you don't feel as smart. That's how a lot of them will describe it. They can't do as much with their mind as they used to be able to. So this is what we're looking at. And by the way, we had a couple more people join us. If you have any questions, feel free to use the chat and along the way, because this is supposed to be an interactive webinar. So if I see a comment, I'll definitely answer it. But I'll just move along in the material, and then I'll have a little bit of a Q&A at the end as well. And this will be a replay as well. So if anybody's watching this on a replay, if you type anything into the chat, it will actually go to my email, and I'll make sure to get back to you about that. Like I said, there's a lot of symptoms, but this is actually from one of the studies. They said despite widespread incidence, MTBI and post-concussive syndrome are poorly understood. And it really is true. When you look at the literature, when you look at the VA protocols, when you look at even the medical protocols, the sports protocols, a lot of it revolves around sitting and waiting and seeing what happens. Rest is best is the common approach. And they do a lot of precautionary imaging. A lot of times if you have a concussion or concussion syndrome, that symptoms that last more than a day, you're definitely going to be imaged to make sure that nothing's going on in your brain. But the greatest majority of the time, nothing is found. And so it's a standard protocol, but it almost seems like we're jumping the gun. And I'm not saying we shouldn't image, but what I am saying is we continuously image in a way that reveals very little, except for a rare few cases. And so we have to understand the mechanics behind what happens in a concussion to understand how to deal with it correctly. Now, I wasn't able to take all this out, but in concussion blast, right, you have a couple forces at work. You have the primary blast, the first wave, which is like a supersonic wave that impacts the body. And one of the things that happens in this, the primary blast wave, let me bring this one up, this is really good, is it impacts into the torso. Let me draw on this for you guys. Impacts onto the torso like this. And when it does, it actually increases the pressure, crushes down on the lungs in the air and fluid-filled cavities. And so it creates a wave of pressurized air out the mouth usually, and it will create a wave of pressurized blood going up to the brain. In a concussive blast from a bomb, from an explosion, that wave of pressurized blood is very unique to it because of the supersonic wave that comes first. And what will happen is it will create so much pressure inside the brain and inside the blood vessels that the blood will leak through and create a little bit of a perfusion into the brain, which is not going to happen in normal concussions because it doesn't have this intense wave of pressure. But what else happens is you have the shrapnel that comes out, and the shrapnel will cause a lot of abrasions, bruising, cuts, and sometimes fractures. And then there's an implosion and then another explosion that's very, very forceful. And that secondary explosion, what will happen, I'm bringing this one up now, is it will cause an impact to the body. Let me clear this off. It literally impacts into the body, and this is much more like getting tackled. Okay, and this wave of force is actually, the second one is strong enough to lift someone off the ground and throw them. And so you have the initial impact of the force as well as the impact of whatever you land on or against once you're thrown. And it can create, what it is it takes the neck, the head and the neck, and it creates a sudden angulation of the head and neck. And it fulcrums right in the area that would be weakest, which is going to be the craniocervical junction. We're going to talk about that in just a sec. But that rapid angular acceleration can be upwards of 160 Gs of force. And to give you guys some perspective, 150 Gs of force is about the amount of force that you get when you take two pro football players and they have a head-on collision. So this is beyond two 300-pound men going full speed at each other. Okay, this is a serious issue in the military, and it's very severely misdiagnosed or underdiagnosed, because a lot of what they're looking at is the hyperperfusion part, which is a concern with these blasts. But these soldiers are getting these severe post-concussive syndromes that are very misunderstood, and a lot of people are just getting medically treated for the symptoms. They're getting pills for the symptoms and not dealing with the root cause of why these symptoms persist. So that's what I want to talk about. Now, what's interesting about this, when you look at this impact, this is causing a huge impact here, and we're calling a blast injury where the blast wave has the biggest lift against the biggest surface. It's going to be your torso, and we're calling it an MTBI for two reasons in the military: hyperperfusion, sometimes a head impact into an object if they fly, but it can also be caused by an impact into the body. Now, there was a very interesting study. It was from the Brain Injury Journal, and they took 183 hockey players from 20 teams in the Ontario Hockey League, from players that ranged from 15 to 35 years old. I am reading off of it because I worded it exactly according to what you guys needed to know, but some had a concussion mechanism of injury and some had a whiplash type injury. So basically, some people got hit directly in the head, some people got hit directly in the body. But what happened is they actually took a look at these players and they wanted to find out what was happening afterwards. And 100% of the injured athletes had signs and symptoms of both cervical acceleration-deceleration, that's CAD, it's whiplash, and mild traumatic brain injury. 100%. The symptoms matched perfectly, but some people got hit here and some people got hit in the body. Very similar to the blast injury. And so what we have right now is a diagnostic protocol to diagnose the person based on where they got hit. So if a player or a soldier or anybody gets hit in the head, the first question is, did they get a concussion? But if they get hit in the neck or in the body and it creates a whiplash type injury, we call it a whiplash or a cervical acceleration-deceleration injury, and we look for disc injuries like you would a whiplash in a car accident. So the location that somebody is getting impacted into is actually determining the way that we investigate where the problem is, instead of looking at it like this. And this is what we're going to be breaking down. If I get hit in the head and my body is relatively stationary, my head will rapidly either hyperflex, hyperextend, or laterally flex, and it creates a fulcrum of force here. If I get hit in the body somewhere, it actually creates a sideways force, and typically we'll see a buckling of the spine with a force fulcruming in the weakest joint, which is going to be also here. It's the same spot. Okay, based on the mechanics of the body and the way the body dissipates force through the body, the most vulnerable area to either a concussive type mechanism of force or a body impact causing a whiplash type injury, it fulcrums on the craniocervical junction primarily. And so this is this is my area of expertise because I'm actually an upper cervical chiropractor. So I spend all my time in the craniocervical junction. So as I was studying this, all these other disconnected thoughts that didn't have a root, whether it was from the military perspective or the sports perspective in athletic training, that is where I noticed that there was consistent symptoms coming from. And when we would get the upper neck corrected, the symptoms would subside regardless of where the force originated in the athlete or soldier. And this has been very, very consistent. So I knew they were getting better. I knew the fulcrum of force was there. Now the question is, why? Why is it happening in this area? So in the military, they actually label the mild traumatic brain injury as a traumatically induced structural injury and or physiological disruption of brain function induced by external forces. And these are the forces that they're talking about. An object has to strike a head. The head strikes an object. Those are both typical concussive injuries that the head is involved. Or the brain, they say the brain undergoing a rapid acceleration-deceleration movement with or without direct external trauma to the head, with or without. In other words, you can get hit somewhere else and it can still cause a acceleration and deceleration of the brain itself, and then blast forces. Those are the ones that they see are very, very typical. Now, there was a very big review that actually took a look at 15,000 different studies. Reviews are usually a group of researchers will pull together material from a large variety of research, and they will look into what it shows. Now, they whittled it down because they were looking for certain criteria that made sure that they were looking at the outcomes and interventions for correctly for mild traumatic brain injury. But this is what their conclusion was. I thought this was very interesting, that no intervention, I think I can highlight, yeah. No intervention initiated acutely, that means right away, has been clearly associated with a positive outcome for patients who sustain a mild traumatic brain injury. And there is little evidence suggesting that follow-up interventions may be associated with a better outcome. In other words, they're saying the research is showing that we're just not getting it done. We're doing a lot, but we're not actually changing the outcomes based on intervention. So we're just doing something, saying at least we're trying, and they can't find a difference, at least not one that's significant enough to consider. So they said, considering the high proportion of patients with persistent symptoms after a mild traumatic brain injury, it would seem essential to evaluate potential treatments to decrease the symptoms. Basically, they're saying, if nobody's finding it and everything we're saying we're intervening, saying we're doing is intervening with the concussion, then we are basically recommending just manage the symptoms and hope the person does okay. That's it. That's what they had after scouring 15,000 articles. But I'm basically coming in and proposing, I really think that what we are encountering is a neck injury with an occasional brain involvement, instead of it being a brain injury with an occasional neck involvement. And I'm going to show you more and more studies a little towards the end that will reinforce what I'm saying right now. But that is literally what I'm proposing, that concussion, although commonly known as a brain injury, is actually a neck injury with occasional brain involvement. Okay? So here's why. This is one of the primary reasons right here. When you go through any type of acceleration or deceleration force, it injures the head and neck simultaneously, okay? And a big part of it is because the head and neck are intimately connected. They're connected through the bones, the skull and the spinal column. They're connected through the neural tissue, the brain and the spinal cord. They're connected through blood vessels and muscles that cross over the entire neck and attach to the skull. So the head and the neck are inseparable, and whenever you do separate it, you call it decapitation. But what I'm talking about here is the reason why we should look at the neck first. So it takes approximately 60 Gs of force to cause a true mild traumatic brain injury. It only takes 4.5 Gs of force to injure the upper cervical spine. Okay, it's actually the ligaments of the upper cervical spine are the ones that are going to go at 4.5 Gs of force. And there's actually been more studies that do say that that's not even the threshold, that there's really no threshold to injury. And a big part of it is because of what you would call plastic deformation. And I wish I had silly putty to show you this right here. But if you've ever played with silly putty, it has to do with the speed of stretch, right? So silly putty, if you take silly putty and you stretch it really slow, you could have your friend, 4.5 Gs of force, one gravity of force is the gravity pulling on you. So it's 4.5 times the force of gravity. Thanks for explaining that. Okay, so 150 Gs or 160 Gs of force, whenever I say G force, it's multiples of gravity. That's how much force is going on to the neck. So 4.5 Gs of force it takes to start tearing the ligaments of the upper cervical spine. But the silly putty example, right? You can have your friend hold one end and you hold the other, and you guys could walk to the other side of the room. And if you go slowly enough, it'll stretch, and just dip down, but you can keep stretching it. If you bundle that silly putty back together and then you take it and you rapidly stretch it, it will snap. And it's because silly putty is designed to stretch over time. It has more of a plastic deformation quality to it. And in the ligaments, if it stretches too fast, it will tear at lower forces than it can actually withstand if you stretch it slowly. This is why sudden impacts often will tear a ligament even at lower forces, or somebody can twist on their own knee. I mean, it's literally your own knee. They could stretch with their entire body weight, but they twist suddenly and it can snap. And it's because of that sudden acceleration of that ligament. So if it takes 60 Gs of force to create a mild traumatic brain injury, that means it's literally 15 times the force required to injure the upper cervical spine. So basically, by the time you could possibly injure the brain, you've already injured ligaments in the upper neck. It's next to impossible not to. But then we keep imaging the athletes for a brain injury and find nothing, and then we just say, let's wait and see. And I think that we actually need to start intervening in the area of most likely injury, because the area of most likely injury is actually not the brain. If it was, then we would see a ton of scans come back positive. And I'll show you how the symptoms of concussion are actually connected to the upper cervical spine. But so if we go back to this, right? So it takes, to actually injure the brain inside the skull, inside of here, it would have to take 60 Gs of force impacting the head. But 4.5 from either direction, either from the head or the neck, 4.5 Gs of force right into that area, fulcruming and fulcruming the force on the craniocervical junction will tear it. Okay. So what happens is we take these criteria that are separated commonly, and what we need to do is look at how they overlap, to not say it's either a head or a neck injury, but instead it could be a concurrent injury of the head and neck and likely the joints between them. Okay. When I was talking about plastic deformation, whenever you injure I'm sorry, can you give an example of what would cause that force? Yeah, if you get tackled in the head, like football is a hot topic right now. Concussion in football is very serious. It's not actually the most common place concussions occur. But if you got tackled in the head, hit with something in the head, you fell and whipped your head backwards, or let's say someone tackled you, you fell off a ladder onto your shoulder and your head whipped sideways and then smacked the floor, any of those would cause a force to both the body and the head and fulcrum on the neck. That's where a lot of the force would travel to. So that's what I'm talking about. There's a variety of forces that can actually cause it. But when I talk about plastic deformation that I was referring to before, if you've ever taken a grocery bag, I really should have brought props for this one, but if you took a grocery bag and you held it taut and then you poked your finger into it, when you take your finger out, it will not look the same again. There will be a dent. So some of the plastic will come back, it will stretch back, but it will also leave a deformation an imprint where your finger was. So when ligaments get damaged, they often cause a plastic deformation. And if you're damaging them at the craniocervical junction, you're leaving the joints between the skull and the upper neck unstable over a long period of time. And the great concern with that is if you got in another concussion injury, another concussive force, or an impact to the body that was hard enough, your neck is already unstable and it can further destabilize it and cause worsened symptoms that come from mostly the brainstem. So it takes lower amounts of force. If you damaged it once, it takes lower amounts of force to potentially damage it again if it's not properly corrected and healed. So that's where I have the greatest concern is this is an area that's not being addressed in athletic training. It's not being addressed in sports a lot, and it's not being addressed properly in the military either, where a lot of these mild traumatic brain injuries are occurring. So when we look at what happens in this upper neck area, there are a couple main things, right? Dizziness is a very, very common symptom after a concussion. A big part of why is when you look at the brain and the brainstem and the spinal cord, you have what's called the vestibular nucleus, which sits in the brainstem, and it actually sits about this low. So here's the bottom of the brain, and then here's the brainstem descending into the spinal cord, and your vestibular nucleus sits about down here. So if you have a forceful enough trauma, you can actually create interference in the nerves that sit inside the brainstem and create a vestibular dysfunction, which would lead to vertigo, dizziness, and a loss of balance, not only in the way somebody walks or runs, but even a loss of balance of strength one side to the other, or a posture imbalance where they start actually breaking down their posture. You'll see curvatures, you'll see postural changes in the head and the shoulders and in the hips, where it won't be even anymore. I'm so sorry. Also, these muscles on the back of the neck, I'm going to change colors for you guys, but these muscles back here send a huge amount of information to the vestibular nucleus that sits in here. And so they send nerve signals to the vestibular nucleus about where the head is in space. And so if the upper neck gets misaligned, it unevenly stretches the muscles of the upper neck, the suboccipital muscles, and it creates an imbalanced input, which will naturally create an imbalanced output to the body, and especially the muscles that control posture. So basically junk in, junk out, okay? But most of that is coming not from the brain. The brain itself doesn't have as many balance centers. The cerebellum does influence balance. The posture control center and the confluence of all of our vestibular inputs is the vestibular nucleus. And so whenever you have junk into that area, you will get junk out, and the athlete will suffer, the athlete and the soldier. Now, this one's really interesting. So a lot of times we'll see eye problems after a concussion. We do a lot of field side tests. Athletic trainers do a lot of field side tests if somebody gets hit hard enough, and they're checking eye movement, ocular movement, the ability to constrict or dilate the pupil. And basically, when you look at the input into the eye, a lot of it comes from, again, the brainstem. All of the nerves, all of the cranial nerves that control eye movement and eye function are cranial nerves. They sit in the brain stem, which is down here. Okay, the atlas bone sits here. So it's directly affecting it. But you also have, there's two other things that will affect it. The C2 dorsal root ganglion does influence a lot of these eye controls. The C2 is the second vertebra down, but the second one is that you have this cerebrospinal fluid, let me do a blue here, that surrounds the brain, and it sits behind the eye. And I'm going to show you in a different slide that cerebrospinal fluid can actually get backed up with an upper cervical misalignment. And when it does, the pressure inside grows bigger, and the fluid will fill up, and that pressure will start to have an effect on the backside of the orbit. and you'll feel pressure behind the eyes to the extent that it can actually cause visual disturbances. What I was talking about with the backup of fluid flow, if you look right here, let me switch to a good color for this. Okay, so this right here, if you can see it, that is, I'll make it thicker. That is the vertebral artery. That supplies blood to the brain stem and the back side of the brain over here. Over here, you have your carotid artery, which you can see sneaking up over behind this jugular vein, and the carotid artery mostly supplies blood to the front side of the brain and the eyes. And then right next to it in blue, you see the jugular vein, and the jugular vein right here drains. It's the main drain of the brain, right? The jugular vein is the main drain of the brain. It rhymes, it's fun, but it's very significant. And so all the cerebrospinal fluid, which would sit up in the brain, and the blood that's flowing up through the vertebrals and the carotids, the main way it gets out is this jugular vein here. And so all three of these blood vessels either sit right next to or travel directly through the atlas bone, okay? So whenever you have a misalignment of this atlas bone at the craniocervical junction, it can actually cause tension and compression on the blood vessels. And the two that we see most commonly is the vertebral artery will strain. It's almost like taking a plastic tubing. If you pull it out, it will actually get more narrow in diameter, so not as much blood goes through it. It can even have a little bit of compression, and what it can also become spasm because of the input to the blood vessels from that brainstem area, and it will cause what's called vertebral artery insufficiency. It means it's not getting enough blood to the brainstem and the back of the brain. And so whenever you have this vertebral artery insufficiency, it leads to balance issues. It leads to sometimes ocular issues. You can't see that well. It leads to muscle, like a lack of coordination in muscle movement. So your movements become uncoordinated, and it's because it's directly affecting the nerves that control those functions, because it's taking away or it's diminishing the blood flow over time. So it's pretty significant. But the other one that we see the most is the jugular vein, right? When the atlas, this bone here, misaligns, it can compress the jugular vein. And I actually see this happen a lot after car accidents, after whiplashes, and often after a significant head injury. And what happens is all this cerebrospinal fluid that should be draining effectively, it can get backed up. It can't get past this point here. So when it doesn't get past that point, this cerebrospinal fluid stays. Now, the cerebrospinal fluid does two main functions. There's a few things, but the two main ones is it nourishes the brain, right? It takes nutrients from the blood and actually delivers it into all the cranial spaces so that the brain is nourished. But it also has the ability to wash through the nerves of the brain, between the cells of the brain, and clear the brain's waste products out. So it's the cleanser of the brain as well. And once that cleaning effect happens, it drains, it's supposed to drain out the jugular vein. So when there's too much jugular vein blockage, it actually causes a backup of cerebrospinal fluid, and that fluid becomes toxic with metabolic waste products, basically. It doesn't clear out, and the brain begins a process of neurodegeneration. Now, from what I can read, and I've heard a couple other people propose this, that actually is a very important piece of the puzzle, because it can be a potential reason why these athletes are getting chronic traumatic encephalopathy over time, where their symptoms get worse, their headaches get worse, their thinking gets worse over time, but they're not diagnosing it until they're dead. So instead, we're trying to understand the precursors of why the brain would break down over time after they stop getting these impacts. And a big, at least proposed mechanism, is that the brain doesn't have the ability to clean itself. And so it literally is sitting in sewer water, and you got to flush the toilet. I don't know if anybody, Jim McMahon, you got to look up the ESPN special on Jim McMahon. And Jim McMahon was a pro football player with the '89 Bears. I believe it's '89. But he, in his special, he actually talks about this. And he saw one of the upper cervical doctors, Dr. Scott Rosa, who's a phenomenal doctor. And when he got his upper cervical spine corrected, he described it as it felt like a toilet bowl flushing in my brain. That's pretty significant. It's pretty significant. So this is a very important component of the misalignment that can affect an athlete and cause a lot of the symptoms that athletes do experience after a concussion injury. Really quick on this one, when your upper cervical spine gets misaligned, it actually causes really bad input into the limbic system, which is your emotional center of the brain, and it causes a sympathetic tone. It's fight or flight, right? And so the big thing that happens, if somebody jumps out at you or a bear jumps out at you in the woods, your body is going to respond in a self-protective survival type mode, and your body will get ready to either fight or run. So your muscles tense, your heart rate increases, your blood pressure increases, your reflexes increase, your ability to solve complex problems goes way down because you don't need to do algebra when a bear is trying to attack you. Your immune system goes down, your healing rates go down, and you don't have to pee, you don't have to poop. All your organ functions diminish because it's going to divert all the blood flow and attention to the muscles so that you live through the scenario. The problem is when it's being driven, when this fight or flight mode is being driven from the inside, it basically leaves you in a state of chronic stress every single day because it's driving the brain into that tone. So correcting the upper cervical spine allows your brain to go into a parasympathetic tone and get out of that fight or flight state. And then we talked about this already. This is just an MRI image of the cerebrospinal fluid flow. But sometimes in these injuries, there can become a corking effect at the bottom of the brain where the cerebellum gets pulled down. Right here is the backside of the opening of the brain, opening of the skull. This is the front side of the opening of the skull called the foramen magnum. And sometimes it can actually yank the cerebellum and spinal cord and the brainstem downward, and it creates almost a corking effect, and it obstructs the normal flow of cerebrospinal fluid. And that fluid is actually supposed to flow down the spine and back up into the cranium. So from the cranium to the spine to the cranium. That's how it's supposed to flow. Any obstruction in this area or a misalignment can cause an obstruction of that flow, and it basically breaks down the brain again. This is really interesting. This is important to see. These are two separate studies that were studying whiplash disorder on one side and mild traumatic brain injury on the other from a different study. And when you look at the symptoms, it's literally 100% match between them. So it didn't matter if you got a whiplash or if you got hit in the head. The outcomes of them were almost identical symptoms in almost identical priority order. This is huge, and these were huge studies. These were big task forces. So this isn't a light study to put this information together. This is a couple research studies, and then I want to show you one more thing. But in this research study here, again, 4,854 records were screened. This is a review. That means they're looking at a lot of research. Cervical spine involvement in mild traumatic brain injury. It's from the Journal of Sports Medicine. They said one of their conclusions was the upper cervical joint dysfunction is most often described in association with cervical symptoms following a mild traumatic brain injury. Funny thing is, those cervical symptoms are the same as the cranial symptoms from concussion or from a mild traumatic brain injury. So these joints have been shown to be the source of neck pain, headache, visual disturbances, tinnitus, and dizziness in patients who have sustained cervical acceleration-deceleration injuries. So basically, they're saying you get hit in the head, it's creating cervical acceleration-deceleration and leads to all these symptoms. We can skip that one, sorry. This is the Department of Defense. The inclusion of neck trauma is important to acknowledge because the most frequent forms of head trauma also cause injury to the cervical spinal column, spinal cord, and the neck musculature. This is huge. right? So this is the mild traumatic brain injury group from the VA, and they've seen literally hundreds of thousands of cases of this. And they're saying this, the only problem is they don't have it in their protocols. They're acknowledging it, but they're not doing anything about it. This is a study from veterans. Among veterans who sustained a concussion, up to 90% report persistent headaches of moderate to severe intensity. And it did seem from the studies to last a lot longer in soldiers than it did to athletes for reasons I explained earlier. A Norwegian study of 348 participants, right, found that headaches related to post-concussive syndrome are often caused by musculoskeletal pathology. In other words, the head or brain injury is not the cause of the persistent symptoms. That's not what they're finding. They're finding is from the neck. They're saying, look to the neck. Cervical impairment, that's what they're saying to look for. This is cervical spine involvement in mild traumatic brain injury. This is the same review from the Journal of Sports Medicine. And they said a thorough evaluation of the cervical spine is essential for limiting the morbidity of mild traumatic brain injury. I'm showing you all these to show you that some of the biggest reviews and the biggest studies out there, the ones that are scouring all the literature, are all saying, stop looking so hard at the head and start looking at the neck. That's basically the conclusion. They're not saying don't concern yourself with the brain. They're saying don't ignore the brain or don't ignore the neck. Continue to look at the brain, that's fine, but definitely look at the neck because everything is saying it seems to be coming from there. This is a great one. The presence of painful upper cervical segment joint dysfunction is what distinguished the post-concussive headache group from the normal group. Basically, if you had persistent symptoms, it was because of joint dysfunction in the upper neck. It's very consistent, okay? I mean, we looked at a lot of studies to get to these conclusions. So they're saying include a precise physical examination of the cervical region. And in fact, they're distinguishing that it's actually the upper cervical region. So best way to put, there's a big question out there actually, and that's why is this getting missed? Why is nobody finding this problem? And when you look at the standard protocols for imaging after either a concussion or a whiplash, if you're in a concussion, you're typically going to go to a team doctor or a neurologist, and they're going to do a brain scan. Now, brain scans do slices of the brain, the MRI slices, and they do everything down to the base of the skull. If you end up in a whiplash injury, typically you're going to be in an orthopedics office or a chiropractor's office, and they're going to order MRIs that typically take detailed slices only up to C2, because that's where the discs are, and they're looking for disc injury. There are currently pretty much no standard protocols for the craniocervical junction in MRI, especially after a concussion type injury. This is a widely overlooked area, especially in the imaging, so they're not finding a lot of this because they're not looking. So what I wanted to introduce to you is what we do with upper cervical care, because this is actually our area of expertise. This is the main area we focus. This is what we're looking at, and we're looking at how the problems in the upper neck are affecting both the body and the brain, because there's so much that goes through that craniocervical junction area. I had a friend, another doctor, who he said, we're the doctors that work between the slices, and he was referring to the standard slices. We do all our work between where everybody else is looking, which is why we find things nobody else finds. But I really think this is a value to post-concussive care. I think this is a value to athletic trainers and teams and coaches and their team doctors. Yes, it is huge. This is a huge resource, because if you have now a resource, a person who's dedicated with your team, on your team, or as a resource to your athletes that's actually looking directly in this craniocervical junction, doing all the necessary imaging and neurological evaluation, then we're going to find the things that other people aren't, and likely find the reason why there's persistent symptoms, even though every standard test is coming back negative, especially the imaging. In other words, you have lots of symptoms, we just don't have a reason why. so let's just keep you out of sports for a while. That's kind of the implication. Let's see what happens. Let's see if your symptoms just get better. Sometimes they do recover, but often, and I see a lot of these cases, somebody will play years in sports, experience a few concussions. 5 years later, they have horrible headaches, pressure behind the eyes, can't think very well, imbalance in their spine, and it's because the injury happened while they were in sports. Everybody cleared them and said, hey, it's A-okay, everything's normal, and it's really because nobody looked in this area at the time of injury, and it should have been. So that's why, this is just a little silly diagram, but rest is best is a really big protocol right now. Rest is best. Just don't do anything. Don't read a book. Don't use your cell phone. Don't use your brain because your brain got injured. But the likelihood of the brain getting injured is quite low compared to the neck getting injured. Pharmaceutical management is a standard protocol for the symptoms. Upper cervical care deals with the underlying mechanics that would most severely get impacted from that force, that concussive force, whether it be from a concussive blast or something like a tackle, or like I think I was saying before, soccer players are some of the most prone to concussion, and a lot of it is because they don't prepare their bodies for impact. They prepare their bodies for dribbling and passing, and when they do experience an impact, it's usually highly unexpected, and their bodies are not prepared for it. So they actually experience worse symptoms a lot of times than even football players would, and more frequent ones. So upper cervical chiropractors, they're a little bit different than typical chiropractors. We are technically primary care physicians, especially in the state of Florida, but chiropractors are trained to identify, diagnose, and treat the main parts of the spine. Upper cervical chiropractors really are trained to address the biomechanical, neurological, and soft tissue structures specific to the upper cervical spine, the craniocervical junction. And typically what we do whenever we see somebody is we will go through a postural assessment, a neurological assessment. We will take x-rays and, if necessary, MRIs. And then we take those x-rays where we measure the bone and the misalignment of the bones, and we calculate how we correct that person afterwards. And so I want to show you that really quick. I think it's on this other presentation. Yep. So this is the technique we use. It's called advanced orthogonal. Let me switch screens. There we go. Advanced orthogonal is a percussion sound wave adjusting instrument. I'll show you it up close in just a second. What we do in the examination process, we're looking at, this is the atlas bone. Let me draw it really quick. So the atlas bone is right there. My arrows are horrible today. I'm so sorry. This is the skull. Right here you have the vertebral artery, which actually passes right through the atlas bone. Your brain stem, which will descend down into the atlas bone area, and in some people even below that into C2. And then obviously C2 under that. This is just a model. There's a lot more structure that's in that area. But we're evaluating what's going on in the craniocervical junction. How is it affecting this person's body and brain and their function? And when we find out, if we find out that the problem is rooted in the upper cervical spine, because we always want to make sure we're moving forward because we found that the root cause of the symptoms or the dysfunction are in the upper cervical spine. So once we find that, then we take the series of very specific x-rays. We'd actually take it from 3 separate views, so it gives us basically a 3-dimensional perspective of what's going on in the upper cervical spine. And we measure them very, very carefully. And so we're looking at the atlas bone from multiple perspectives to see exactly what's going on with that bone and the rest of the bones it's connected to, the skull, the C2, and the rest of the cervical spine. That gives us the ability to get vectors so we can set up this percussion sound wave instrument to make a correction to their upper neck. And so the advanced orthogonal uses a percussive sound wave. So this stylus here sends a sound wave down it. It's not going to impact on the person. The stylus isn't going to hit them. It's actually going to release a percussive sound wave. So percussion, just so you know, is the quality of sound that has force. It's just a descriptor. So sound, anytime you hear something, it's because force left another object, traveled through the air, impacted on your eardrum, and it had enough power to vibrate your eardrum, which we interpret as sound. But sound itself has a force quality to it. And so we harness that force quality of sound, and we create a percussive sound wave, and we're aiming it at the atlas bone, which sits underneath the skin here. And when we release that force, it actually helps us shift the atlas bone and the upper cervical structures back into proper alignment, which would remove the interferences and obstructions. It would start to improve the nerve signals that pass through the area. It would take pressure off of nerves that had direct pressure on it. It would allow the cerebrospinal fluid to start flowing correctly, as well as take pressure off things like the vertebral artery and the jugular vein. So now we're getting correct blood flow to the brain and correct drainage out of the brain. And I've seen a number of cases like this, and it's very, very consistent. They usually, get kind of tired because their brain has had so much gunk in it. But when they wake up afterwards, after a nap, they often feel this sense of relief. And a lot of them will describe this feeling of just pressure draining from the head after the upper cervical spine is corrected. So through this entire Recovering from Concussion webinar, the one thing I wanted to do is basically say, upper cervical spine should be a part of the management protocol of athletes that encounter a concussion. And not just athletes, it's really true of anybody. So obviously we reached out to a lot of athletic trainers with this webinar. This is a very essential component of recovery from concussion in these athletes. And so a lot of times there's a lot of relationships built with neurologists and team doctors that will evaluate for concussion. Upper cervical chiropractors, maybe not the typical field, but upper cervical chiropractors really should be part of the management protocol, because it really sets up the correct environment for the long-term health and function of the brain. And I've helped get a lot of athletes that were really doing poorly, get them back on the field, get them back in the game, and it's because we're correcting the root cause of a lot of their symptoms. In the rare case that you have somebody that has a true brain injury, obviously they might need some more intense intervention. But upper cervical protocol is a very non-invasive approach to correcting a lot of the functions that get interfered with after a concussion. So I would really love to hear from you guys. If you have any questions, just really quick, before anybody gets off, I want to make sure you have my contact information if you don't already. My email address is drslinninger@ucbrandon.com. I'm sending it into the chat here. So you can always email me with some questions. I'd be happy to answer any. Also, if you type anything in the chat, that'll go right to my email as well. But I would really love to help these athletes get back to full function after these concussions, or even things that are sub-concussion, but they still have some of the symptoms that are very, very similar to concussion, because likely it's coming from the craniocervical junction and the brain stem being affected from a misalignment up in the upper neck. So what are your questions? This was an hour presentation. I shared a lot of information. What are your thoughts? What are your questions? I'd love to hear from you. If you have any questions, I'm going to stay on for a few minutes to make sure any of them are answered. I know Lindsay is an athletic trainer. She doesn't work as much on the field right now, but once in a while does do some field work and works a lot and networks a lot with other athletic trainers as well. I wish I could hear you so it could just be a conversation, but I don't mind at all. And again, if you're watching the replay and you want to send any questions, either just directly email me or type in the chat. I'll make sure to get back to you with any questions. So one of the things that I would definitely say to athletic trainers is that if you ever do a field side evaluation and someone loses the sense of smell, because that is a direct brain nerve. It's the only one that goes straight up to the cranium. If they lose their sense of smell, it's an emergency. And it's because you're dealing with a really bad problem with the brain. The rest of them are brain stem related and can still be affected by problems in the brain, but are more likely to be affected by problems in the brain stem. Also, I was going to tell you about one thing. Let me pull this slide up. If anybody has questions, again, I'm still waiting for that. But I wanted to show you something where it is the jar, right? So the argument for the brain smacking the inside of the skull is that there's the ability for the brain to impact really hard on this. But again, if you take away the air, there's nowhere for the fluid to move rapidly. So it's much harder for it to truly smack against the side. But what can happen especially when the container, or in the case of the brain, it's the skull, is really close to the edge of the brain. So this egg thing is now our brain. What happens is the brain can move very rapidly towards the surface of the skull, and it does increase the pressure here. That can happen. So although you might not be, and maybe in some instances, I'd like to see a study where the model doesn't have air in it. But what does happen is the pressure increases, and it increases to the extent that it would shove the fluid forcefully between the nerve cells, and it actually causes these cells to separate. And that can cause micro damage in the nerve cells. And if not healed properly or cleaned out properly, that could lead to some of the things that you do find later on after a concussion and post-concussive syndrome imaging. So that's a model that makes a little bit more sense. But the smacking side of it, in a closed system with only fluid, it's much, much harder to do. But increased pressure with hyperperfusion, that is one that is possible. And there's one more. And Lindsay, I got your question. Since I'm on this one, I'll show this really quick. The other one is if you get hit across the face and you have a rapid rotation of the head, even in a closed system with closed fluid and no air, if you took that jar and a floating brain inside of it and you rapidly rotated it, in the brain, it's actually attached with the pia mater, and it can shear the pia mater because it's rapidly rotating it. And that one can cause some serious brain injury as well. So a hit across is a little bit more dangerous to the brain, but a direct blow impact is more likely to be something in the craniocervical junction. Lindsay asked, does recovery time decrease with early upper cervical intervention, or is it still case by case? As far as I can tell, and I've heard other people report, early intervention is much better because you're very quickly returning all the nerve signals and blood flow and cerebrospinal fluid flow to normal, which means even if the brain itself does have some damage or micro damage in it, it's going to have a better environment to heal if all those other hydrodynamics inside the brain, the fluids, are working correctly. You're getting good nutrient, good oxygen, and getting the gunk out of the brain. So it would, from that standpoint, it would increase recovery time for true injury. But if the symptoms are related to an interference or a neurological interference in the brainstem, it's going to rapidly increase the recovery time because you're removing the insult. You're removing the problem very, very quickly afterwards. And this is true not just with concussion. We talked about how whiplash injuries and hits to the body also create that same cascade of problems, the same symptomatic outcome, pretty much. In whiplash injuries, car accidents, things like that, the exact same thing is true. Makes complete sense. Awesome. All right. So if you have any other questions, I'll still stay. For anybody else, though, if you don't have a direct question, I just want to thank you so much for the time that you put. I do ask this one favor, though. If this was helpful, And if you know somebody, this would help. This would be a coach. This would be an athletic trainer. This would even be potentially a neurologist or someone who deals with concussions regularly. Somebody who you know who either deals with concussions or could benefit from the information in this. Maybe even an athlete or a parent of an athlete who had concussion and they're really trying to figure it out. You guys are gonna be getting a replay link. It'll be sent to you directly, and I'm also gonna send it out through social media and through the Upper Cervical Center's email. Please forward this to them, because this information really could change the long-term career landscape of somebody who's trying to get into athletics or play in sports even through college, and it might make the difference between them getting into something like a professional sport, or being able to play through college and maintaining a scholarship so that they can go. The main thing is I don't want somebody to play sports and the cost of playing sports is the deterioration of their brain. That's the main thing. And so I just want to get this information out, because upper cervical care needs to be at the forefront of the concussion discussion, especially when so much research is saying, look in that spot anyway, look in the upper cervical spine. So again, thank you so much for your time. And I'm going to go ahead and end the call, but the chat will still be open. So I'll stay a few more minutes so that if you have any questions, you can ask them. Again, email me if you'd like to. If you're watching the replay, leave a chat. And thank you so much for the time.